Good afternoon. It's good to be here. This project has been called MAGIC. It's an implementation project that was funded by the Health Foundation in London. I want to tell you more about that. And Maureen Fallon, you heard her speak briefly this morning, is the lead of this project in Cardiff now. It's got a life for another 18 months. I'll tell you more about that. What I'd like to do before diving into the detail is to just share thoughts that have been going through my mind this morning. I've been doing this probably for about a decade, this stuff, as I call it. And you know what? The less confident I get that we've got a handle on this, particularly the measurement piece, the less confident I get that we're meeting those three challenges that Karen so neatly and Dawn so neatly put up, for the challenge for research, the challenge for feedback to clinical practice, and the challenge to the organization that we've got a measure that is accountable, where judgment might come in on the quality of a team's practice, a person's practice, and an organization's delivery of care. The less confident I am, and we've got this right. When I started doing shared decision making, there were two voices I always heard. We do this already. And I keep hearing that. We do this already. Go away, we do this already. That's from the providers. And from the patients, I kept hearing, what would you do, provider? It's your job to make the decision. And I keep hearing that as well. And I don't think we can avoid these two voices, really, because the assumptions we're making is that patients are ready to take on the decisional responsibility. And we may need to have a halfway house here, which is probably the basis of the paper that Al Mully, Chris Trimble, and myself put together recently for the King's Fund about stop doing the silent misdiagnosis. Patient preferences matter, is that this is a job for the professional to help people understand what their preferences might be, but not to give them the total responsibility for making that decision. It's too hard. I don't expect that at the moment in our culture. Maybe it'll change, but it's too hard. And when you're ill, I know that I wouldn't want that responsibility totally. So those big assumptions which we've heard this morning underpinning all this research area, that we should measure the patient's involvement in decisions, we may need to rethink. That's just a kind of preface to what I'm going to present, because I've been in the other paradigm of trying to measure this stuff, and I'm not sure we're getting it right. I'm going to talk to you about this breast cancer service in Cardiff. Just notice this. This was prepared by a breast surgeon. 120 patients have a genuine choice between radiotherapy, in other words, lumpectomy or mastectomy. They see probably about 400 patients a year, but they only think that 120 have a choice. What do you think about that? Actually, everybody has a choice of a mastectomy or a lumpectomy, because lumpectomy is the more conservative issue. It has more recurrence of breast cancer. Sure, it has a conserving nature on the breast, but maybe, as Karen has demonstrated in a study, people don't worry so much about that when they're approaching 70 or 80. So the assumption in this team was that only a few people should be given this choice. What does that tell you about the culture of the provider system we've got? And I think I heard from John Spurt is the same, is that we assume that clinicians want to do this. I don't think that's the case. Okay, the study. This is a very large project, and I won't tell you all the details. But just to say that we've tried to put shared decision-making into the organization from top to bottom, from clinical teams right up to the board level. We've got the chief executive on board, we've got the management team on board, we've got tried to engage the middle managers, which is a devil's job actually, because they're carpeted and sacked for not meeting their budgets. They're not sacked for not doing shared decision making. So we've tried to do it across the organization using a different set of tools. We've even prompted the patients to ask questions using the beautiful Sydney work of Ask 3 Questions, prompting the patients to ask 3 questions. So I won't tell you much about this magic project. If you're interested, let me know. One of the things that we had to do, almost like necessity is the mother of invention, we had to create very brief decision tools. We didn't have the long decision tool, the DVD or the website. They weren't available to us. There are plenty of these in the US, but there wasn't one readily available in the UK. So we decided to make option grids. I'll tell you more about those in a moment. They're very brief, one-page tools which are organized by the questions that patients frequently ask, or that we think they should be asking. And that organization of the comparison of option by frequently asked questions has been helpful, I think, to patients, because as soon as they feel that other patients have asked these questions, they feel the permission to ask them themselves. Because it's a big threat to ask questions to a professional. It's an even bigger threat to disagree, as we've shown in some focus groups. Here's an example of one, and if you Googled option grids, you'd find 12 more published in your own time. Essentially, what they do is to put the frequently asked questions down here, and then you read across here, what about difference in mortality? There's no difference in long-term mortality between these two procedures. What about the recurrence rate? Well, there's a big difference. 5 in people in 100 have a recurrence with a mastectomy, 10 in 100 have a recurrence with lumpectomy. So you begin to be able to see where the differences are between these two treatments. I'm not going to say much more about these tools, apart from the fact that clinicians like them, seem to want them, and we've got a collaborative going that's making quite a few more of these. We also decided on the basis of this to measure decision quality. And here I pay homage really to Karen Sepuka's work and Al Mully's work, who came up with this beautiful construct of decision quality. I have no argument with this construct whatsoever. Patients who are informed and who make decisions that are aligned with their informed preferences is a beautiful construct. It's a devil's own job to measure it. And here's what we found. We measured this in the breast team. It took us a while to get them to understand that this was important to measure. That was the first hurdle. But we couldn't get the preferences that we were asking to align with their intentions. We asked, well, what would you intend to do? We couldn't get alignment. And Karen has managed to get alignment on the preferences and decisions. We didn't manage this. So we had a problem there. The team in Cardiff declined to use the questions that Karen had produced in her original breast cancer tool. They just said, we don't accept these questions. They're not the part of the knowledge we convey to the patients. So we had a problem. So we had to change them. We worked with Karen permission to do this. We actually had to change most of them. And so we decided to change them to these. And this is a true-false question. I don't know if you can read them, but not all of them are true. I won't go through them, but these are the questions of knowledge that we asked. They're at a very high level, I think, of the kind of patients that come through a service. So think about whether it's fair to ask these questions to patients who are anxious about the diagnosis and so on. So anyway, those are the questions. We also had an idea that it would be good to measure a readiness to decide. Do I feel enabled, ready to decide? And these were the items of a scale we're working with, not been finalized. We had 10 items in Cardiff, now we've reduced it with some psychometric work down to 5, and these are the 5 items. About thinking about the decision phase, can you answer these questions? Yes, no, or unsure, basically. So we've, maybe wrongly, but not sure about this, we haven't published it yet, called this decision quality measure, where basically we're concerned about readiness and informed. And the sweet spot is being informed and ready. All the other spots on this matrix are no good. We've tried to see whether this is operationable in the clinic, and whether the providers would be happy with it. So we used it at the end of the diagnostic consultation. I'm very sorry, Mrs. Hughes, you've got breast cancer. Now would you be prepared to answer some questions? And then at the end of the home visit, with the nurse does a few days later. And these are the sample sizes. It took us months to get these data, and they're not very clean data. It's an implementation project, so bear with us. We used this, and here's the interesting bit about this data, is that the nurses wanted to see their patients' answers to these questions. They really were interested in the moment, not just as an analysis piece a week later. They checked whether their patients were getting the scores right. So from a kind of immediate feedback to the nurses that were doing this coaching with the patients, they found it incredibly valuable. Here's the data. We're just going to compare at the moment the knowledge before we started using the option grid and after using option grid. No control here, just pre and post measures, but a big change. Here's knowledge when we did the first decision quality measure at the diagnostic consultation versus the one at the home visit. So you see a shift in knowledge here between the pre-visit and the post-visit of the nurses. You would expect that. The nurses are talking, but they're also using these tools. But it's nice to see the knowledge gain. Here's readiness to decide, the deliberate score. Again, quite a fair amount of people saying that they're ready to decide, actually without much knowledge, I would say. And here we can demonstrate a big shift in readiness to decide. So does it make a difference to the kind of choice of treatment? Well, what we can demonstrate is that people move from the unsure side to the sides. They move to having a strong preference for either lumpectomy or mastectomy. And we can see again this kind of comparison of whether people were going more for mastectomy or lumpectomy at the different points. And it varies a bit, actually. You can see, I mean, we've just cut this off. But from memory, this is the strong preference for mastectomy, is the orange here, and blue, strong preference for lumpectomy here. It varies a bit between the time points. So it's not weighing people one way or the other, it's allowing people this equipoise. Here's the knowledge scores, again, between the average knowledge scores at post-diagnostic consultation, home visits. Again, you see a big shift upwards over time as the nurses learn to get better at transmitting knowledge and are using the option grid increasingly. So I would say that from this implementation project, one of the two most big successes that are carrying on into the second phase are the use of the option grids and this redux version of decision quality measure. So a reduced measure. But here's some thoughts and some concerns. Now, I think this decision quality, as I've mentioned, is a beautiful construct, but I'm not quite sure we've got a workable measure, which is a composite measure of these. It's difficult. And I also think that the construct match between the researcher concept and the interpreted item by the patient is not always true. Patients don't know what we mean when we ask these questions. It's a really difficult thing to get right. And this issue applies to most measures in our field. So I kind of feel that operationalization of the decision quality is really difficult. And here's one of the Achilles heel we all face. I'd love to be able to demonstrate knowledge gain across all the medical decisions we face in medicine. But there are thousands of decisions, literally thousands. And I don't think the policymakers are going to wait until we've got validated, reliable, and acceptable measures of knowledge across all the different decisions. The Cardiff one don't agree with the Boston ones, for example. And I think that could be replicated elsewhere, possibly. We found that the predetermination of preferences is problematic. What patients say was that actually it was anti-flow's problem that influenced me most. And anti-flow's problem wasn't on our preference list. It was something else that was driving their decision. So we've got this alignment, inconsistency. So a proposal is that a simplified, informed and ready tool might be the way forward. I say might, I'm not advocating that, because it doesn't get over the problem that there are thousands of decisions. So after a decade, if you like, of thinking and working on this, I'm a bit flummoxed, to be honest, as to how we go about this. Measuring the process of sure, the 4 items might be a way, but it's highly subjective. And as Karen would say is, people don't know what they don't know. They might think they're sure, but actually when you probe under the skin, you find very little validity in that certainty, essentially.